Assalamu alaikum. Good evening, everyone. I am Dr. Bahar, anesthesia senior specialist in Dalla Hospital, Riyadh, KSA. Our lecture, inshallah, this night is about ultrasound nerve blocks. I mean, general principle or background to help you to give nerve block. Our objectives are pharmacological background of local anesthetic, anatomical background, and soon anatomy, how the nerves appeared by ultrasound, and emphasize role of ultrasound nerve block in the critical ill patients. What we need to know before doing the block. 4 hours, right dose, right drug, and antidote, right place, right patient. What's meant by right drug means pharmacological principle. Local anesthetics are divided into 2 main groups, ester group and amide group. Usually you are using lidocaine and ibuprofen, which are amide group, metabolized in the liver by amides, hepatic amides. If we look to this table, we will see the dose of lidocaine is 3 ml per kg. For ibuprofen, 2 milligram per kg. Regarding the onset to lidocaine is fast, ibuprofen even medium. Usually, for short procedures, we use lidocaine. For long procedure or for post-operative analgesia, we use ibuprofen. We can add adrenaline to lidocaine to increase the duration and increasing the dose. The dose can reach 7.5 milligram per kg. However, some text of anesthesia mentioned that also adrenaline can be added to ibuprofen. We can add adrenaline as a famous vasoconstrictor to achieve longer duration and deeper depth of the blood. Warning, if you meet patient with seizure disorder or heart failure or renal or hepatic impairment, or any patient received propranolol or antihistaminic, especially type 1, keep in mind those patients are susceptible to the toxicity of local anesthesia. Keep in mind. What about the local anesthetic toxicity classification? Direct local toxicity, direct injury to the nerve, to the muscle. Systemic toxicity means adverse systemic effect of high blood concentration of local anesthetics. The etiology is direct intravascular injection or excessive amount absorbed into the circulation over the short period. Manifestation usually started by CNS manifestation, by tinnitus, circumaural numbers. Usually we note that in anesthesia. This manifestation called pre-excitation. The next manifestation will be seizures and motor irritability. Motor irritability, then seizures. Airway obstruction, loss of airway reflexes, respiratory depression, and cardiovascular manifestation usually preceded by CNS manifestation. Cardiovascular usually excitation first, then depression. Tachycardia, arrhythmia, then bradycardia, VF, asystole. So now we can imagine the risk of these drugs. So could anyone imagine the antidote for these medications? I will tell you. The antidote for this medication is lipid emulsion 20%, intralipid or smooth lipid, whatever its name must be available beside you when you are doing the block. Right place or goals. Our goals to allow circumferential spread of local anesthetic around the targeted nerve. The requirements to achieve this goal is well anatomical knowledge and practice of ultrasonography guided nerve block and to know anatomy, how the nerves appeared on ultrasound. Right patient, choose the patient. What is the indication? What is the contraindication? What is the relative contraindication? Indication, painful procedure or condition. Painful procedures like growing nail, trauma, condition, any traumatic fracture. Contraindication, first absolute contraindication is the patient refusal. Then local infection. Coagulopathy is relative contraindication. You can weigh the risk and the benefit and decide carefully. We start by femoral nerve block. This lady is 99 years old, came to ER with severe hip pain after fall on the floor. Pelvic X-ray, fracture neck femur. This is a famous fracture in elderly patient. And it is dangerous. Usually the patient has multiple comorbidities, diabetic, hypertensive, ischemic heart, any cardiac issue, fragile, and these patients usually stay bedridden after the surgery, susceptible to more complications. The history of our patient showing she has diabetes, hypertensive, and cardiac issue. Echo demonstrates severe aortic stenosis, severe tricuspid regurg, severe pulmonary hypertension, and ejection fraction was 55%. What do you think about analgesia for this patient? If you met this patient at ER, let's see what we have as a painkiller. Paracetamol, good, no problem with this patient, but it is weak. Non-steroidal, what do you think about non-steroidal in this patient? This patient has diabetes and hypertensive. Maybe has diabetic nephropathy, hypertensive nephropathy. So this patient has a risk of acute renal injury with non-steroidal or renal impairment in addition to gastric ulcer. What about opioid? This patient has sensitivity to opioid. The sensitivity is increased to respiratory depression. So, especially this patient, if you give morphine and the patient started to get respiratory depression, then hypoxia. Remember, this patient has severe pulmonary hypertension. The pulmonary blood pressure will increase and the catastrophe will come. So, if we decide to give nerve block, what do you think? Fracture neck femur, logic, femoral nerve block. So, I must know the anatomy for this region, the nerve supply for this region, the anatomy of this region. Choose which local anesthetic I will give. Keep in mind general condition of the patient. Okay, let's start. This is a cutaneous or dermatomal supply of the thigh of the patient. If we see anterior aspect of the thigh is supplied by femoral nerve. Lateral aspect is lateral femoral cutaneous nerve of the thigh, and the medial aspect is ilioinguinal and obturator. This dermatomal supply is very important for anesthetist for post-aortic analgesia due to skin incision. But if you are in ER, This is not important for you, but the most important is nerve supply of the bone. If you look at the left side of the screen, you will see that the anterior aspect of the femur, the main nerve supply is femoral nerve, and the posterior aspect, the main nerve supply is sciatic, and medial part or medial half of the femur is supplied by obturator nerve. So from the anterior aspect is supplied mainly by femoral nerve. So if I decide to give nerve block as analgesia in this patient in ER, I will give femoral nerve. What about the anatomy of femoral nerve? The femoral nerve passes behind inguinal ligament, just lateral to femoral vessels. If we see here, from the medial is femoral vein, femoral artery, femoral nerve, and this is the ilioinguinal ligament at the level of inguinal crease. Here's a cross-sectional area. If you imagine that I put ultrasound transducer above the inguinal crease, we will see from medial to lateral femoral vein, femoral artery, femoral nerve. Femoral nerve usually lies above the iliacus muscle and covered by fascia iliaca and fascia lata. Before the block, you must stop and follow these guidelines from Regional Anesthesia UK. First, drugs and equipment must be ready and available and well prepared. Drugs means local anesthesia. Antidote, repeat it again, is very important to get intralipid emulsion 20%. Drug of emergency, suppose any hemodynamic instability or even cardiac arrest happened, you must be ready. Okay, and take your time, prepare well, choose your patient, choose your drug, choose your dose according to the patient condition, and start. This is a position of the right thigh of the patient, and this is the position of transducer above the inguinal crease. This is linear transducer, linear probe technique, emblem from lateral to medial. This is a sonoanatomy. If we look here, this is a hyperechoic structure is fascia iliaca. This is iliacus muscle or iliopsoas muscle. This is the femoral nerve, usually hyperechoic structure lateral to femoral artery. If we zoom the picture, this is femoral artery, femoral nerve, fascia iliaca, and iliacus muscle. If we come here by the needle from lateral to medial, just before the nerve, for a few millimeters, you can inject saline as a hydrodissection or hydrolocation to be sure where is the tip of your needle. If you are sure you are in the right position, immediately replace the saline with local anesthesia and start to inject. Usually the dose for femoral nerve block is 10 ml to 15 ml. Lidocaine 20%, 2%, sorry, or bupivacaine 0.25%. Our extremities blocks. Usually in anesthesia, we give supraclavicular block or interscalene block. However, according to SonoSchool curriculum, we will explain, we will demonstrate the nerve blocks for wrist or for hand surgery or painful conditions. If we look at the anatomy, here the anatomical distribution or dermatomal supply of the hand. Major nerves, radial nerve, median nerve, ulnar nerve from the anterior and the posterior. We can target this nerve at the forearm or the mid-arm, but according to SonoSchool, we will target this nerve at mid-forearm. So it is called mid-forearm block, sorry. Here the position of the probe, mid-forearm. Also, we use linear probe or linear transducer. This picture demonstrates the relationship between the vessels and the nerves and radial bone and ulnar bone. Here, ulnar artery and the ulnar nerve. In the middle of the forearm exactly is median nerve. All nerves appears as honeycomb hypoechoic structure. Here the radial nerve and the radial artery above the radial bone. Keep in mind in this area, many tendons, many muscles appeared also hyperechoic structure. So if we decide to give nerve block, scan the nerve. If it has a course like that, okay, this is the nerve. But if doesn't has a course that it is lymph node, sorry, it is a tendon or muscles or anything like that, but not a nerve. Here the anatomy of median nerve in the middle of the forearm, hypoechoic structure. This is two muscles and it is encapsulated in between. Here where the needle must be and the local surrounding the median nerve, and here the position of the transducer. If we decide to give ulnar nerve block, you can rotate your probe toward the medial aspect of the forearm, then you will get this picture. Ulnar artery beside ulnar nerve, and this is ulna. And if you see to the left of the screen, you will see where is the needle must be put, and the local spread around the ulnar nerve. If you decide to give radial nerve, rotate the probe toward the radial bone. You will see this picture. On the left, where the needle must be put, and the local surrounding the nerve, just beside the artery. Here is the sonoanatomy of the nerve and the artery above the radial bone. Again, take care, you must scan the nerve along the forearm, up and down. It has the same course that okay, this is a nerve. If not, it is tendon or muscle or anything. Here, if you decide to block the nerve at arm, this is called mid-arm block. This is the only radial nerve at spiral groove. Here we reach the end of the lecture. Summary. We must know the pharmacological principle of local anesthesia, type, dose, antidote. We must know the anatomy and sonoanatomy. And after this lecture, I demonstrate the real role of POCUS in acute pain management, especially in critical ill patient, as I mentioned in my patient. This patient is a real patient I met here in OR, and before spinal anesthesia, I give her femoral block, 10 ml lidocaine, 2%. Then the patient can sit. I give spinal anesthesia, and after the end of the procedure, I give her fascia iliaca block. Fascia iliaca block blocks obturator nerve, femoral nerve, lateral femoral and save the thigh. It is called 3-in-1 compartmental block, but it is outside curriculum of SonoSchool. Thank you, everyone. Assalamu alaikum.